This is Digestive tract tutorial presented by the SchrDbb reference Atlas of Histology with Function and Clinical Correlation by Dongmei Cui. So we start with the introduction of the digestive tract histology. So we start by naming the different part that constitute the digestive tract. So it consists of the esophagus, it consists of the stomach, the small intestine, and the large intestine. So the general structure you need to know that is made up of the walls of the digestive tract are generally made up of the mucosa, the submucosa, the muscularis externa, the serosa, and the adventitia or the adventitia. So those are the four main layers. Now the esophagus, generally you have to know that what the esophagus is divided into three. You have the upper esophagus, the middle esophagus. Upper esophagus made up of skeletal muscles, middle esophagus made up of mixed skeletal and smooth muscles, and lower esophagus, the lower third, which is made up of the smooth muscles only. Now you have the stomach. Generally you have to know that the stomach is divided into four parts: the cardia, the fundus, the body, and the pylorus, and each of them have their specific characteristics that we're going to see in the histology sections later. Now we have the small intestine. So for the small intestine, the small intestine is generally divided into three: the duodenum, the jejunum, and the ileum, and each of them have their specific characteristics. Then the next one, you have the large intestine. The large intestine is divided into the cecum, the appendix, the colon, and the rectum, and the anal mucosa. And the peculiar characteristic is that the large intestine is going to have not a continuous band of the longitudinal muscle, but instead strips of longitudinal muscles. Is it clear? So now we start with the imaging. So on the imaging, we have the esophagus. This is generally how the esophagus resembles. Then the stomach imaging, this is generally how the stomach imaging resembles. Small intestine, this is generally how it resembles, and the large intestine, this is generally how it resembles. So these are the different, the summary of the digestive tract. So let's start now with the proper images. So now you need to know that for the stomach we said that it is made up of a mucosa inside closer to the lumen. Then you have a submucosa. Now the muscularis externa of the stomach is made up of three main layers. You have the oblique muscles, then the next layer is the circular muscles, then the next layer is the longitudinal muscle in the muscularis externa, and the last layer is the serosa, which is at the level of the parietal epithelium, the visceral peritoneum. Sorry, so that serosa is in contact with the visceral peritoneum. Now the next one, this is now the small intestine. So it's still made of the mucosa, and in this case the mucosa is made up of the epithelium, the lamina propria, and the muscularis mucosa with the different glands. Then you have the submucosa, then the muscularis externa is only made up of the inner circular muscle and outer longitudinal muscle, and lastly you have the serosa adventitia. Now the large intestine with its mesentery is made up of cell, the mucosa. With the mucosa we have the muscularis mucosa, the lamina propria, and the epithelium, as you can see here. Then you have the submucosa, then you have the muscularis externa. So for the muscularis externa, you need to know that you have the circular muscle is continuous in the large intestine, and then the longitudinal muscle are discontinuous, that is, they are producing longitudinal bands, as you can see here. And then the last one is the serosa adventitia. So those are the layers. Now let's start with the esophagus. So the overview of the esophagus, you need to know that generally this is the esophagus diagram. It's made up of the mucosa, and then so you have the mucosa, and the mucosa consists of the epithelium. It consists of the lamina propria, and it consists of the muscularis mucosa. Those are the three main layers of the mucosa. Then the next layer is the submucosa, and then the next layer is the muscularis externa, and then the last one is the adventitia. So generally you have to know that the word adventitia is better to be used for esophagus, and the other you better use serosa. Is it clear? So it's better to use the other serosa, because the serosa is more of a mesothelium, while the adventitia is more of a connective tissue. And then you need to know that what the serosa is a mesothelium, and the only structures which are close to the mesothelium are the stomach, the small intestine, the large intestine, except also the rectum and the anal canal, which can also have the adventitia in those cases. Is it clear? Because they are attached now to the walls of the pelvis and the perineum. Is it clear? So now the next one is also upper esophagus. So how do you distinguish upper, middle, and the lower esophagus? So this is the hematoxylin stain and the using stain of this high magnification. So you can visualize here that in the upper esophagus you have a mucosa. Still inside that mucosa you have the esophageal glands inside the upper mucosa. You can see the esophagus is made up of esophageal gland and also have the submucosa. So esophageal glands are located in the mucosa of the upper esophagus. Now these are the ducts here of the esophageal glands, and this is the increased magnification of the esophageal gland. Then we have the inner circular muscles, then we have the outer longitudinal muscles. All these inner and the outer longitudinal muscles are only skeletal muscles. As you can see, this is the diagram of skeletal muscles. Skeletal muscles, as we know, we have seen the muscular system tutorial. They were longitudinal, as you can see here. They were straight cylindrical muscles with nuclei located at the periphery. So you can see that these are actually skeletal muscles here in the upper esophagus. Now let's go down to the middle esophagus. In the middle esophagus, you see that, so here there's also the tissue layer. I forgot to speak about the epithelium here in the esophagus was the stratified squamous epithelium. Is it clear? Now in the middle esophagus, still the epithelium is going to be stratified squamous epithelium. Then we have the lamina propria, and then we have the muscularis mucosae. Now in the lamina propria, we don't have any esophageal glands again. We don't have esophageal glands inside the middle esophagus. The esophageal glands are absent in the middle esophagus. Now in this, then the next one is submucosa containing blood vessels. After that, now we have and also the lymphoid tissues. After that, now we have the inner the muscularis externa. The muscularis externa is made up of inner circular muscle and outer longitudinal muscles. So the circular muscle and outer longitudinal muscle, both of them, it constitutes of the smooth muscles and then the skeletal muscles. Skeletal muscles are striated, one, and then they are also cylindrical, while the smooth muscles are not striated and they are more spindle in shape. Is it clear? So they are more mixed muscles, both skeletal and the smooth muscles located in the middle esophagus. Now the lower esophagus, here you see at the level of the lower esophagus there is a junction between the stratified squamous epithelium and the simple columnar epithelium, which is also found inside the stomach. Is it clear? And this simple columnar epithelium help you to resist the gastric juice. Is it clear? So it protects it. Is made up of a goblet cell that is going to be helping to protect the surface of the lower esophagus from the gastric juice. Is it clear? So that is it on the mucosa. So we also have the lamina propria, then we have the muscularis mucosae, and then we have the submucosa and the muscularis externa. Now the muscularis externa here is only made up of the smooth muscle, and also we need to know that the lower esophagus is also made up of the esophageal gland at the level of the lamina propria. There are also esophageal glands, and this esophageal gland help you at this level because the lower esophagus with the stratified squamous epithelium. At the level of the lower esophagus, the stratified squamous epithelium here, it does not contain yet the goblet cells. Is it clear? So in order to provide now mucus that is going to line in order to protect this lower stratified squamous epithelium here, there is a need for it to contain the esophageal glands. So the esophageal glands are going to be found all through here in order to prevent the gastric juice to affect the stratified squamous epithelium here, because the stratified squamous epithelium don't have a peculiarity of production of mucus. So it needs to contain esophageal glands such that it produces mucus such to prevent the gastric juice irritation. But now this other part here that will contain the simple columnar epithelium do not have esophageal gland here. Why? Because as from here their goblet cells are going to produce mucus at this level such that it's going to protect the esophageal mucosa. Now the clinical correlation of this lower esophagus is Barrett esophagus. You need to know that Barrett esophagus is a pre-malignant change which is due to a recurrent gastroesophageal reflux disease. Is it clear? Now in the histologic section, you're going to have, so you see, you're going to visualize a metaplasia. So you have a squamous, you have a metaplasia of the tissues. So there's a metaplasia. Why? Because the stratified squamous epithelium are every time going to be irritated by the gastric juice. So there is going to be conversion of stratified squamous epithelium here to simple columnar epithelium, which is normally found in the gastric mucosa. So when there is that conversion now, it's going to be called Barrett esophagus. So that's why you can visualize metaplastic Barrett epithelium with goblet cells, and those goblet cells are going to help it to prevent from a continuous irritation with the gastric juice. Is it clear? The next one now is esophageal carcinoma. Now you need to know esophageal carcinoma is a malignant neoplasm that stems from a epithelial cell lining at the inner surface of the esophagus. And generally, the most common esophageal carcinoma is a squamous cell carcinoma. Why? Because the esophagus is mostly made up of the stratified squamous epithelium. So generally, it is squamous cell carcinoma. And the causes of squamous cell carcinoma, the risk factors are alcohol, tobacco usage. Is it clear? Then later, after the stratified squamous cell carcinoma, the next most common cancer of the esophagus is going to be adenocarcinoma. Is it clear? So that's the next esophageal cancer, adenocarcinoma. So on this squamous cell carcinoma, you can see squamous cell carcinomas, you can see squamous cells, as you can visualize here, and you also see keratin pearls. So those are the histology section that you're going to visualize on that cancer. So the next thing to visualize now is the stomach. So the stomach is going to be divided into different parts. You have the cardia, which is the esophagogastric junction. You have the fundus, which is here. Then we have the body, which is here, and then the last one now is the pillows. So now let's visualize the different diagrams. So we start with the cardia. So the cardia is made up of, here this epithelium is the epithelium of the esophagus with stratified squamous epithelium. Then there's a conversion to simple columnar epithelium here, basically. And then the simple columnar epithelium in the cardia or cardiac region is made up of gastric pits. You're going to see gastric pits here. Is it clear? And then we are also having cardiac glands. Both you have gastric pits and you have cardiac glands. Is it clear? Those cardiac glands are going to produce mucosa that are going to help also in the that's going to help in production of the gastric mucosa, in addition to the gastric pits containing, which are containing goblet cells that are going to also produce mucus. Now the next thing is the fundic region. So the fundic region, at the fundic region of the stomach, we have also gastric pits, many gastric pits here. Is it clear? As compared to in the case of the cardia. So the gastric pit is where we have cells that are going to produce gastric juice. Is it clear? In addition to the goblet cells. So these cells that produce gastric juice are divided into two. We have parietal cells and we have chip cells inside those gastric pits. So we also have many fundic glands that's going to produce mucus for protection of the gastric mucosa. But these cells that are at the level of the gastric pits are producing both are divided into two, parietal cell, and then there's also chip cells. The parietal cells are the one that produce hydrochloric acid, while the chip cells are the one that produce the enzymes such as pepsinogen, which is going to be activated to pepsin. Is it clear? So that's it. And now we also have other cells inside the stomach. Is it clear? So these other cells are going to be more found at the level of the body of the stomach. Is it clear? So in the body of the stomach, you still have the gastric pit, we have the lumen here, we have the lamina propria, we have the fundic glands, and we have other cells inside the mucosa. And these other cells are called the enteroendocrine endocrine cells, is it clear? And those enteroendocrine cells can those other cells are called enteroendocrine cells, and those enteroendocrine cells produce example of that consists of the G cells, and those G cells produce gastrin. Other cells you have the D cells, and the D cell produce somatostatin. Is it clear? Gastrin is going to help in the stimulation of the gastric juice, while somatostatin is going to help in the inhibition of the production of the gastric juice. Is it clear? So the pylori regions of the stomach, they are in the pylori region of the stomach. We have most of these cells. We have most of the endocrine cells, that is the G cells and the D cells. So you visualize on the diagram, we have still the mucosa, we have the gastric pit here constituting of the parietal cells and the chief cells. We have the parietal cells can also be called the zymogen cells, and the chief cell, the parietal cells are also called the oxyntic cells, and the chief cells are also called the zymogen cells containing the peptic granules. So now we have the pyloric gland and all that. So these are the gastric pits, the surface mucosa, and all this and the cells inside, which are going to be involved with that. So now the clinical correlation. So what is the clinical correlation now of the gastric mucosa? So the clinical correlation of gastric mucosa is going to be gastric ulcer or peptic ulcer. So peptic ulcer is a chronic mucosal lesion, is it clear, which is mostly due to an infection from Helicobacter pylori or due to excessive exposure to anti-inflammatory products. Is it clear? So now this is the histologic section of a gastric ulcer. So in histologic section of gastric ulcer, you're going to see many granulation tissues. One, you're going to see fibrinous or fibrinopurulent exudate of the ulcers. That shows an ulcer. Number 3, you can see gastric mucosa with intestinal metaplasia. Normally, the gastric mucosa should not resemble that of the intestinal mucosa, but when you have gastric mucosa changing to intestinal mucosa with an intestinal metaplasia, it can make you think of a gastric ulcer. And the last one is chronic gastritis, chronic inflammation of the stomach. Now we have the next one is Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is just a gastrinoma, and a gastrinoma is a neoplasm producing excessive gastrin, which is commonly arising in the duodenum and the pancreas. So when you have those gastrin secreting tumors at the level of the duodenum or the pancreas, you have hyper secretion of the gastrin. Now at the level of the pancreas, you can have a histology section, you can have normal pancreatic tissue, and you have gastrinoma tissues. Is it clear? So that is the image of the gastrin. So now the next one is the small intestine. So for this is the small intestine overview. We have already seen this image. Now for the small intestine, you need to know that it's made up of the duodenum. So the duodenum is this part here. So on the histology section of the duodenum, you still have the mucosa, and you have glands of the duodenum at the level of the mucosa. Then you have the submucosa. In the submucosa now, we have the Brunner's gland, and the Brunner's gland still produce mucus to protect the duodenal wall from gastric juice. Is it clear? Because the gastric juice consists of a pH of which is very acidic. So it both has the glands of the duodenum and the Brunner's gland to prevent it from being affected from the excessive secretion from the gastric juice. Is it clear? So and then underneath it, you have the muscularis externa and then the serosa. So still in the stomach here, this diagram shows a higher section of the Brunner's gland. So here you can see you also have at the level of the mucosa, you have glands of the duodenum, and at the level of the submucosa, you have the Brunner's gland, which is there at the level of the submucosa. Now the next one now is the clinical correlation of this. So the clinical correlation of this is going to be peptic duodenitis. So peptic duodenitis is an inflammatory process caused by chronic exposure of the duodenal mucosa to gastric acid. Is it clear? That's peptic duodenitis. So what do you see on peptic duodenitis? So you are going to have metaplastic changes So metaplastic changes from an jejunal mucosa to a gastric mucosa. So it's going to change from jejunal mucosa to gastric mucosa. Is it clear? And then you have blunt widening venous inflammation. Now we also have other histologic features like fungi-like villi. We have increased inflammatory cells in the lamina propria. We have Brunner's gland hyperplasia. We have Crep's hyperplasia, and we have gastric faviolar metaplasia of the epithelium. So the Brunner's gland hyperplasia is going to also occur while in order to prevent excessive irritation to gastric juice by protecting the mucosal wall. That's the clinical correlation in hepatic duodenitis. Now, this next image is going to be the plicae and secularis of the microvilli. Now, this is the diagram of, you need to know that in the villi and the microvilli are more located at the level of the jejunum and the ileum. So, the villi consist, so they are plicae secularis of the villi. So, you need to know that what this is a villi which to increase surface area for food reabsorption. At the groove surface of the villi, we have the crypts. So these are the crypts now called the crypts of Lebesgue, and the crypts of Lebesgue constitute of cells that are going to secrete. Is it clear? So this is the schematic representation. This schematic representation, you can see villi. Here is the lumen of the gland called the crypts of Lebesgue, and this is here underneath. Here we have the Paneth cells. The Paneth cells are going to produce intestinal juice. We also have endocrine cells that are going to produce the different hormones like the D cells to produce somatostatin. We have the lacteal duct, and then you also have other capillaries and blood vessels involved here. Then these are the columnar absorptive cells, and these are the goblet cells which are interspaced between the columnar and the absorptive cells, and these are the microvilli of the columnar absorptive cells. So this is the diagram of the histology section. So you can see one goblet cell here, and this is the columnar absorptive cell close to it here with its nuclei. Is it clear? And underneath you have the lamina propria, and then underneath you have the muscularis mucosa, and then you have the submucosa. So this is the diagram of a villus of many villi. So these are villi here with the lamina propria underneath. You can see epithelium underneath, and then you have the submucosa here with the muscularis externa and the serosa. So now this is what are the columnar absorptive cells? Since the diagram of columnar absorptive cells and the goblet cells. Goblet cells are seen here. These are the columnar absorptive cells, still at the level of the small intestine. So this is the electron microscopic view of the goblet cell. So the goblet cell, we have a cup-shaped cell consisting of many mucous granules, and then these are the absorptive the enteroabsorptive cells close to it. Now, at the level of the crypts of Lebesgue, don't forget that there were cells called the Paneth cells, and the Paneth cells have basally positioned nuclei. So their nuclei are basally positioned, and they contain acidophilic granules, meaning that they are more eosinophilic and pink shaping color. Is it clear? So these secretory granules contain lysozyme, it contains tissue necrotic factor alpha, it contains defensin, that is cryptidine, and these are antibacterial enzyme that help to regulate the normal bacterial flora in the intestine. Is it clear? So those Paneth cells are just involving to produce antibacterial products which are going to be secreted. And we said the peculiarity of Paneth cells is that they have a basally positioned nuclei, as you can see here, and then they also have eosinophilic granules, and those, as you can see here, these are eosinophilic granules, the basally positioned nucleus at the level of the crypts of Lebesgue, and those secretory granules constitute of antibacterial products like lysozyme, tissue necrotic factors, and defensin to control the normal flora in the intestine. So these are still Paneth cells, and these are endocrine cells here. But now this is a diagram of an endocrine cells. So the endocrine cells are there are many types of endocrine cells. They are also called neuroendocrine cells. Is it clear? They are all hormone releasing cells of various types. Is it clear? So those are endocrine cells. So to know endocrine, you can use electron microscopy, where you are going to visualize the nucleus of endocrine endocrine cell, you see mitochondria, you see secretory granules, you see basal lamina, you see endothelial cell capillaries. Now, at the level of the submucosa, you need to know that at the level of the submucosa of the intestine, we have the Meissner plexus. Is it clear? So the Meissner plexus is just a plexus of nerves that is going to control the normal peristaltic movement of the intestine. Is it clear? So this is the glandular epithelium here. So the glandular epithelium, like the crypts of Levaquin, we have neuroendocrine cells. Now underneath, now we have the submucosa, and then in the submucosa we are going to visualize that there are certain neuronal bodies inside the submucosa. Is it clear? In the submucosa you have certain neuronal bodies. Now out of the submucosa, that is between the circular and the longitudinal layer of the muscularis externa, we are going to visualize the albar plexus. So let's visualize here. So here or the mesenteric plexus. So here is the muscularis externa. Now in the muscularis externa, between the inner circular muscles and the outer longitudinal muscle, we have a plexus here of nerves, and those nerves are going to be called the albar plexus or the mesenteric plexus, and this is the plexus of nerves here. So this is still the albar mesenteric plexus. So this is in a small intestine. You can visualize between the inner and the outer longitudinal muscle. You see albar plexus with pale staining cytoplasm, as you have seen in the chapter on nerve tissue. Now the duodenum and the small intestine. So at the level of the duodenum, you have many villi. You can see many villi here at the level of the duodenum. And the difference between the duodenum and duodenum is that the villi in the duodenum are going to be very extensive, and they are very long compared to the duodenum. You have also the crypts of Levaquin here, and then underneath you have the submucosa. You have the inner circular muscles there, and then the outer circular muscle here. You can see how the villi are very long. So at the level of the ileum have pair patches in the submucosa. So the pair patches are just mouths, are just mucosa-associated lymphoid tissues that we have already seen in the latter chapters. So this is still the mucosa. So this is still the mucosa you can visualize. Now the pair patches are in the submucosa. Is it clear? So clinical correlation is that vitamin K is absorbed in both the duodenum and the ileum, but vitamin B12 is only absorbed at the terminal part of the ileum, especially the terminal ileum. So the absorption of vitamin B12 require the coupling of the intrinsic factor that is produced by the parietal cells, and so the coupling of intrinsic factor produced by parietal cells, these two substances become so we have a coupling of vitamin B12 and the intrinsic factor from the parietal cell. That two substances now make vitamin B12 to be absorbed at the level of the terminal ileum. So if there is no intrinsic factor produced by the parietal cell, vitamin B12 is not going to be absorbed, and then the patient is going to suffer from megaloblastic anemia and neurologic symptoms like peripheral neuropathy. Those are the diseases that the patient will suffer from. So now the mucosa of the intestine, of the ileum or the small intestine, you see that here in the ileum, you see that the villi are not as extensive as in the duodenum. So that was a very difference that I wanted to speak about here. And then the ileum contained much of the ileum. The difference with the duodenum and the ileum is that the ileum consists again of more of pair patches. That's mucosa-associated lymphoid tissue. Now the next structure that you have to speak about is the large intestine. This diagram we've already seen before. So in the large intestine, it consists first of the colon. So the colon is still having the same layers. You have the mucosa, you have the submucosa, and then you have the muscularis externa. Now the muscularis externa has different, but you have the circular muscle layer, and which is continuous. So while the longitudinal muscle layer in the large intestine is not continuous again, it's going to be having shapes of longitudinal muscle. So like this can be one shape of the longitudinal muscle, and this is the circular muscle which is continuous. Is it clear? So the large intestine still, so this is the diagram of the large intestine. So here is going to be, so the large intestine at the level of the colon contains some crypts of Dongmei Cui with the Paneth cells, and the Paneth cells are going to still produce the antibacterial substances. Is it clear? So those are the clips of diverticula you can see at the level of the mucosa. Now, still the mucosa of the colon, you have columnar absorptive cells. Here you need to know that the colon is mostly the main part that's involved with the reabsorption of fluids, and that's going to make your stool to be in a harder form. So those are the goblet cells at the lumen of the gland. So what is the clinical correlation? So clinical correlation of the colon is that you can have a colon polyp, and a colon polyp are tissue masses that grow on the inner mucosal surface and protrude into the lumen of the colon. Tissue masses going into inner mucosal surface, proceeding to the outer aspect. So there are several types of polyps, the most common of which is adenomatous and hyperplastic polyps. And how do you visualize polyps now on a colonoscopy? You can see a protruding mass on colonoscopy. Then you have on histologic section, you can visualize stereostratified columnar epithelium. Normally they are not stereostratified columnar epithelium in the colon, they are instead simple columnar epithelium. But when you visualize stereostratified columnar epithelium in the colon, just know that it's a metaplastic change and maybe a polyp. So the next one, you have colorectal cancer. Colorectal cancer is a malignant neoplasm of the colon or the rectum. Is it clear? So the risk factors include genetic, inflammatory bowel disease, especially ulcerative colitis, adenomatous polyps, and other. So this is most adenocarcinoma is the most common cancer of the colorectal cancer. So that's why on the histology section you can see adenocarcinoma cells. Is it clear? So here you can visualize many glands. That's why it's called adenocarcinoma. Adenocarcinoma are cancer produced due to excessive formation of glands inside particular tissue. Now the next one is the Merkel diverticulum. Merkel diverticulum is a congenital abnormality characterized by outpushing of the small bowel due to failure of the vitelline duct to involute. Is it clear? So here is on the histology section of the Merkel diverticulum, you can see ileal mucosa. It has the same mucosa as the ileum. It has also another same mucosa as the gastric glands. Is it clear? So he has ileal mucosa. There is ileal mucosa inside the Merkel diverticulum. There is also gastric mucosa, ectopic gastric mucosa inside the Merkel diverticulum. I also have some colonic mucosa inside the Merkel diverticulum. So it is made up of heterotopic mucosa. So different mucosa type. Is it clear? That's why a patient that has Merkel diverticulitis has different clinical presentation. Can have so differential diagnosis of Merkel diverticulitis can be peptic ulcer disease. Why? Because it still has gastric mucosa that can present as ulcerative diseases. It has ileal mucosa, so the patient may also have intestinal obstruction and all these form of diseases, or appendicitis presenting still we are saying Merkel diverticulitis. Is it clear? So now this is the appendix, and the appendix is made up of a lumen. It's made up of the mucosa and the submucosa. At the level of the submucosa, we are going to have lymphatic nodules at the level here. So you can visualize many lymphatic nodules, and then you have the muscularis externa and the serosa. Now appendicitis, you have already said that appendicitis is due to its result of bacterial infection or viral infection that's going to result to overgrowth of this mucosa that's going to obstruct the lumen of the appendix, and that's going to result to bacterial translocation and inflammation of the appendix. That's how the pathophysiology of appendicitis occurs. Now anorectal junction is a junction between the rectum and the anus. Now you need to know that what the rectum is much more made up of simple columnar epithelium, and the anus is made up of stratified squamous epithelium. So there's a junction there. So still with the muscularis mucosae and the glands or the crypts of the ligature. So here is the rectum, and here is more of the anus. So this is the anal canal with the stratified squamous epithelium here and the large veins here. So the clinical correlation at this junction is going to be hemorrhoids, and hemorrhoids are swollen inflamed vein in the anal region deep in the anal mucosa, and are classified as internal hemorrhoids and external hemorrhoids based on whether the hemorrhoids are above or below the anorectal line. So that's why the anorectal line, the line that distinguishes that's between the anus and the rectum, is very important. So how do you visualize on the histology section hemorrhoids? You're going to see dilated anorectal veins on hemorrhoids. So the next clinical correlation is ulcerative colitis. Ulcerative colitis is an inflammatory bowel disease that causes ulcer in the lining of the colon and the rectum. You need to know that what ulcerative colitis do not go above the ileosacral junction. It starts from the sacrum downward to the rectum, basically. And then on the histologic section, you can see acute and chronic inflammation, and then you see Krebs abscess on the histologic section. Then the next one is Crohn's disease. Crohn's disease is also another inflammatory bowel disease, basically. And then this it may be due to the location of Crohn's disease is going to be variable as compared to ulcerative colitis. For Crohn's disease, the location is going to be variable. It can start from the oral cavity and then go and extend to the rectum, basically. So here for the histology section of Crohn's disease, you have non-cassating granulomas. Here you had acute and chronic inflammation with Krebs abscess. Here you had the non-cassating granuloma and then cryptitis on the histologic section. So this is everything on digestive tract. So if you want to see the summary of digestive tract, you can just pause and visualize all these elements. So you are finished with this chapter, then we move on to the next chapter, which is digestive gland. Thanks for your kind attention.